Ivan. So I'm Eleonora Harwich. I'm Director of Research at a think tank called Reform. And as Ivan mentioned, in this session, we will be discussing the commercialization, healthcare data and commercialization, which is a topic that actually everyone on this panel has written a report about. And we will specifically be talking about the nature of partnerships developing between organizations in health and care, like hospitals, GP practices, or other central bodies like NHS Digital, and the private sector when that data is used to develop innovations. So there have obviously been absolutely amazing partnerships that have developed between the NHS and the private sector that have enabled the development of new diagnostic tools, of better treatments. And there are actually quite a lot of rules and regulations about, what type of data you can access, for what purpose, what you can do with that data. But the rules actually become much less clear when it pertains to the nature of the commercial agreements between the public and private sector. So prior to this pandemic, there were already partnerships developing within health and care, and there were some concerns about the kind of fairness of those commercial agreements. Since the pandemic crisis, there have been obviously many tech companies that have lent their expertise to develop algorithms and different types of tools to help with the situation. And here actually we've kind of ended up in a similar situation where the media have reported on how some of these kind of commercial arrangements might not lead to the kind of long-term benefits of the healthcare system. So to discuss some of these kind of difficult issues, I have a fabulous panel with me. So we have Annemarie Naylor, who's Director of Policy and Strategy at Future Care Capital, Reema Patel, who's Head of Engagement at the Ada Lovelace Institute, and Lord James O'Shaughnessy, who is Visiting Professor at the Global Health Institute at Imperial College London, and who is also the ex-parliamentary Undersecretary of State for Health and Social Care, who was obviously very involved when he was in that position in this whole debate. So I will actually ask you to introduce yourselves a bit further and maybe tie in your perspective on healthcare data and commercialization and some of the research that you have all done in this field. So I will go first to you, Reema.
Thank you. Just unmuting myself. So I'm Reema Patel. I'm Head of Public Engagement at the Ada Lovelace Institute. We convene a lot of deliberative public engagement processes with members of the public, and we ran some citizen juries on this very issue.
Thank you very much, Reema. Annemarie, over to you.
Hi, everybody. I'm Annemarie Naylor, so I'm Director of Policy and Strategy at Future Care Capital. We are a charity, long-standing, with a focus on data, technology, innovation, scaling and investment across the health and social care landscape. Over the last 3 years, we've written extensively on the subject of how we share healthcare data at a local level, what kinds of data institutions or vehicles are most appropriate for stewarding different types of health and care data. We've looked in great detail at demand for healthcare data, so who's interested in making use of the data that is both controlled by but also newly generated with NHS organisations. And we've also taken a keen interest in how investments in cleaning up data in the healthcare system might also contribute to the levelling up agenda.
Thanks, Annemarie. That's actually a paper that we both worked on together. James, so could I move on to you for introductions?
Yeah, thank you. So James O'Shaughnessy, as Eddie said, I'm a former health minister, and when I was a health minister, I had responsibility for the tech, digital and data agenda. And since leaving, I've written on this topic with colleagues at Imperial. The inspiration really for the work that I did as a minister and subsequently has been to really try and understand what it would take to get the public to be supportive of a data sharing agenda. I think we are in a very fortunate position in this country where the NHS is the most trusted institution, even more so after the COVID crisis. But at the same time, we know people are acutely aware that their data needs to be properly stored, ethically used. And if their very precious health data is going to be used to generate economic value as well as health value, they've got a very keen interest in making sure that that's done properly, and indeed that the NHS gets an opportunity to share from that. And actually, if we don't have that bedrock of trust from the beginning, as we've seen, not only do we get media stories, but more fundamentally, we erode that trust that people have in the NHS. And that ultimately means that we won't be able to realise the gains, the huge health and economic gains that we have the opportunity of getting as a country. And so really, the work that we've done has been trying to create a strategic framework for action to understand what are the main areas of action that we need to take, both on public trust in terms of the law and governance, and value sharing models and other things, to make sure that we can make the most of this opportunity.
Thanks, James, and thank you very much. We clearly have a wealth of expertise amongst our panelists. So actually, maybe to kind of ease in the audience into this conversation and to try and understand what it is that we know about commercial partnerships, could I maybe go to you, Annemarie, and to try and understand, well, what is it that we know about partnerships? And I know that you've kind of done particular research looking at the demand for data.
Okay, so about 12 months ago, we undertook an in-depth exercise to try to understand what kinds of data are stored where in the health system, because obviously the health system isn't a single unified body, but more of a Balkans and myriad organisations, approximately 100,000 health data controllers in the UK at present, by our reckoning. And we tried to understand what data controllers, what types of data those data controllers had in-house, what type of data they also generated with different types of partners, and then understand something about the demand for those data sets. So we undertook a freedom of information request, approached every NHS trust in England, and from that we're able to tell from a fairly decent response rate, details of which are on our website, how many organisations demanded data at different points in time over the last 3 years, but in particular what types of organisations were really keen to access that data that was already controlled by NHS trusts. In particular, the highest demand comes from higher education institutions and from other NHS organisations seeking to understand how the system is working and work with one another. And in terms of commercial interest, explicit commercial interest, the thing that we found greatest demand amongst were pharmaceutical companies. So curiously, not necessarily technology companies, unless they in some way partner with the higher education institutions that came up top. The demand was greatest in London, the West Midlands and the North West. But we did have a significantly lower response from larger NHS trusts, whom we might ordinarily expect to be allied with teaching hospitals, medical schools, and therefore be more interested in kind of research, data-driven research and innovation. So there's some caveat to the data that we were able to obtain. And clearly demand for data doesn't necessarily translate into commercial revenues and income streams for those involved. So we can't categorically say at this point in time whether that map of demand for data across the country actually maps also to commercial revenues accruing to those individual NHS trusts. But what we would say is that the top 15 trusts in the country are involved in around about 300 studies in 2017-18, whereas the bottom 70 were in 35 or fewer, based on data from the National Institute for Health Research. So from that, you get a kind of a strange map across the country, a sort of X map, which looks like approximately 80% of data deals we estimate are done in about 20% of trusts. So going forward, we're going to be taking more in-depth look at those 20% of trusts, working again with Ellie from Reform, to try and understand what level of enterprise and innovation flows from them.
Great, thanks, Annemarie. And actually, James, I know that you have also mentioned and written a report on this. So what are the kind of different types of partnerships, or the shapes that partnerships can kind of take?
Yeah, no, thanks, and I'm indebted to everyone on this webinar as well, who's contributed to my thinking. I think, you know, Anne-Marie's point is a good one. Data has always been shared to generate economic value. The traditional way of doing that has been through clinical trials for the development of pharma. I think the truth is now that obviously advances in computing power and so on mean that we're just able potentially to get much more value out of that data and to get it more immediately, and to link that value with specific individuals or cohorts or trusts or whoever it is. So it is a radically changed picture, albeit one with a sort of historical hinterland. And part of the problem up to now is it has been a very decentralized system. Hundreds of trusts operating differently, not really a clearly accepted rules of the road. Yes, we've got ICO guidance, but but not at the level of granularity that we really need. And so a part of the work that I did as a minister and have been doing since is to provide greater guidance and support for trusts that want to get into data sharing and data using relationships with others. One of the things that's going to be happening at a national level, slightly obviously put off by the COVID crisis, is the creation of a national centre of excellence to support trusts, and that's important to address the issue that Annemarie raised, that at the moment it's 20% trusts doing the bulk of the work, whereas this actually is a value generating opportunity for multiple trusts. But then you come to the question of what does value look like, and there's any number of ways of doing it, and I would recommend for people wanting a more comprehensive look at this to go and look at the Imperial IGHI website for our white paper, because there's a table on this. But that ranges from no value sharing, which is obviously not a great outcome, to looking at providing free or discounted products, all the way through to actually sort of profit or royalty shares, right the way through to ownership. It becomes more complicated and more difficult and more long-term the more you move across that spectrum. And at the moment, probably the capacities aren't largely there to negotiate those more complex relationships. Over time, those are the things that you would expect to yield the most value. So I think part of the national strategy that we need to have is about improving expertise that sits in trust, that sits at the centre to develop and negotiate these kind of deals. Not to be greedy, not to try and capture all the value, because of course if you do that, nothing will happen, but to make sure there is a fair share of value that passes the public's very acute sense of whether this is providing the sort of feedback to the NHS in income that is acceptable.
Yeah, thanks, James. And actually, Reema, talking about kind of public perspective, you obviously did a lot of work trying to understand how the public feels about different types of partnership models, how it feels about commercial access. So could you kind of potentially give us a little bit of a kind of 101 into how the public feel about this?
Yes, absolutely. So the citizen juries that we convened were in Taunton, Leeds, and London, so quite different location. And we supplemented this work with a survey, also did some patient roundtables and worked closely in collaboration with Understanding Patient Data at the Wellcome Trust on this project. And the reason that we use the methodology of citizen juries is because this is a complex issue. It's incredibly fraught with difficulty. And in particular, what's challenging about it is that the complexity of the system. So, the extent to which data isn't really with a single individual. There's a range of NHS trusts, and data is currently being shared and governed in very different ways. And it felt that we needed to have a really deep conversation, share information about how data was happening in the system before we could get meaningful and really interesting public input on this question, which was what does a fair relationship, a partnership look like between the NHS Trust and third party. Industry organisations are part of that, but academic and research organisations are also a part of that. And there were some key themes. The first point is what does fair look like, and how is that articulated? And in that context, people recognised that the NHS in isolation couldn't, in isolation, realise the full benefits of data user management without being able to enter into these partnerships. So there's a really important role there for these partnerships, but they were also incredibly concerned about the risk of exploitation and asymmetries of power between the NHS and in particular large third-party organisations. And this was a really consistent theme, and it came up in all of the workshops that we hosted in all of the region. As a result of that, they wanted some clear assurances and safeguards around the trustworthy, legitimate use of data and around the governance of these health data partnerships. One interesting area was in terms of being able to clearly articulate what public benefit looked like, what social value looked like, and be transparent about that as a basic, but also to ensure that there are accountability mechanisms in place should people feel that those benefits were not being realised or it wasn't clear what that would look like. Another key theme that came up was this question of value exchange. So it's quite difficult in some instances to measure or capture what value data sharing or data access might have to the NHS, but people felt that was really important as well. That's quite different in nature of value exchange for an industry organisation. And one other key point, which is really important to mention, particularly in this socioeconomic context, is the importance of equity and fairness and fair distribution. So when people reflected on the role of the NHS as a universal healthcare provider, they felt there was a central role for the National Health Service in terms of ensuring that the benefits from healthcare partnerships such as these were fairly and equitably distributed. So they wanted to see mechanisms that would enable that. And some workshops, notably in Leeds and in Taunton, there was a concern that the partnerships happening in a fragmented way at a local level might contribute to unequal health outcomes across the country, or unequal health outcomes for particular groups, or from people from ethnic minority backgrounds, or people from one location that may benefit from what's coming from a health data partnership, but not for others. So there's much more on this. It's quite difficult to speak to the in a short slot. So you can check out our website on the other points, but those were the key themes.
Yeah, and I do definitely recommend that you look at the report. And actually, something that came as a kind of emerging theme from all of your answers was that kind of interesting language around kind of fair apportioning of value, maximizing value, and it kind of feels that in this debate there are kind of two schools of thought. There's kind of one that seems to at least use a bit more of the kind of semantics around maximizing value, and then another one that is a bit more around fair apportioning and what that means. So I was wondering if I could, maybe kind of ask you all, where do you feel that you kind of sit on that spectrum, and how you would define that position? So could I possibly go to you first, Annemarie?
Sure. So I think it's first important to stress that we're talking about different types of value that may be derived from healthcare data. So we're talking about clinical value and direct patient benefits in the first and foremost sense, but we're also talking about wider social benefits in terms of health populations that might benefit from the use of data. We're talking about socioeconomic benefits. So we're talking about economic development amongst SMEs that might use that data to generate new products and services in the healthcare space. And then we're talking about commercial benefits potentially also for the NHS. And not importantly to forget all the data, the sort of data that's being collected currently as a result of the pandemic, which is administrative data to understand whether we've got enough beds, staff, PPE, etc. in different parts of the system. Some of that data is perfectly capable of driving a kind of an environmental agenda as well in terms of benefits. So that's the first thing to say. So that makes the land rather complicated to say, do you want to maximise all of those things or have a fair apportionment of value? I think what you more readily end up with is thinking that you need a differential value framework, which is something we've been trying to develop in partnership with the National Consortium for Medical Imaging, Intelligent Imaging, and then we've been trying to look at in what instances you would want to have more clinical value or more socioeconomic value or more environmental value from different data sets, and try to be somewhat more subtle than simply say it's about fairness or it's about maximising the value. That said, during the last general election, people may recall a great deal of talk and concern about the future of the NHS in the context of future trade negotiations, for example. There was considerable coverage, to my surprise, in fact, more coverage, not of data being sold, but of being given away to particular large tech firms from overseas. And there was clear sentiment expressed, at least across my social media feeds, that people didn't want it given away. So I think that echoes what Reema has been saying. And then I think on that basis, the last thing I want to say is to basically say, why would you treat data any different to any other public asset in which taxpayers have invested? So we obtain best value where we have local government controlling land and buildings that they might acquire, develop, sell at a point in time. So why don't we expect the NHS to obtain best value and maximise the value rather than fair value?
Great, thanks, Annemarie. James, could I potentially kind of go to you to know where you sit on that spectrum?
Yeah, well, maybe I could start with just a little sort of story, which is we know that the Treasury has become quite interested in intangible assets, and indeed had a review on them a couple of years ago. And when I was in the department, we commissioned Ernst & Young to look at the potential value of the NHS data asset, and they came out with a nice round number of £10 billion. And it's usually the case that if you go and talk to the Treasury about things to do with health, and they assume you're after some money, and they don't particularly encourage that conversation. I can tell you their ears pricked up when they saw the 10 billion figure. And that, in a way, is a slightly cautionary tale, because if you know you've got the Treasury on your side, it does tend to mean you get things done, but it also means that they see money there. And and when I say money, what I mean is fiscal value, value into the exchequer, even more so than economic growth. And so I think one of the things we have to be careful here is not just to balance, as Annemarie has said quite correctly, between the sort of health and economic value, but that we don't sort of kill the golden goose by trying to extract as much as possible into the Treasury, because while public are very supportive of health data and value generated from it being used to support a better NHS, I can promise you they feel quite differently if there's a sense in which that value has been hoovered up and is not going to be directed into the health service. And if they felt that 6 months ago, they feel it even more now. So I think a really important part of that is to understand that this isn't just about, to Annemarie's point, exploiting an asset. This is about trying to foster an asset that will grow in value over time, and which throws off multiple types of benefit that can be harvested in different ways. But if we don't enunciate really clearly that the primary goal is health and social value and the other goals are secondary, then the risk is that we lose the public support, as Reema has pointed out.
Yeah, thank you. Reema, would you have kind of anything to add on where you sit on that spectrum?
So I think what's really interesting through the citizen juries is the way that people mapped out different types of value. But broadly speaking, it felt there were three narratives being articulated in terms of what the value is, and that these narratives were quite distinct. The first narrative is around the narrative of data as an asset, so a commercial benefit to the NHS, but also to the organisations that receive it. So often narrative being accompanied by something like data is the new oil. But also we overlook the value that data has to the people who it relates to. So it has value to me if I'm a patient. And people talk about this in terms of data as akin to a digital shadow. That's quite different to the way we think about data as a commercial asset or a commodity. Then there's also another way the NHS might think about the value of data, which is this is something we want to steward. It is of and for and by society. And it's quite challenging because when people talk about value, sometimes it feels they're talking about one or two of these things, but not all of these things. Or they're talking about the same thing, but actually they're talking past each other. And so the notion of value is something that we want to unpick. What narratives are being told about what data is, and how do we ensure that we're telling the right narrative, the one that is something that is important and truly reflects who we are as a society. And some people might argue, certainly, that some narratives are clearer and more resonant in our conversation about value than others.
No, that's really interesting. And I think, I guess, in general, as human beings, we're not that good at dealing with complexity. So it's often a kind of binary choice that we kind of try and at least have in our minds, because, optimization under constraint with many constraints is very complicated to do in our heads. So actually, we've been receiving quite a lot of questions from the audience, and there are a couple that are picking on this theme of ultimately how do you engage patients or the kind of population at large when you're kind of having these discussions about commercial value, because obviously, we can do a kind of citizens jury at one point in time, but feelings and views might evolve depending on the application. They kind of might be very specific. So in terms of the types of governance models that we would imagine moving forward, would you have kind of any recommendations or ideas of what you would like to put in place? Maybe I'll kind of jump on again and see if Reema, you have kind of any ideas about this.
So you've got 2 points. One is, to what extent does the public's views shift and change and evolve? And I think it's fair to say it's really important to keep a good keep a sense of how people's views have evolved and shifted and changed. We have done a public deliberation process and have found through that in the last 3 weeks that people are somewhat increasingly critical, have offered quite a lot of scrutiny of approaches to data sharing, partly because it comes from a place of wanting to trust the institutions to work most effectively for them. We ran a deliberative process before the Cummings episode and then after the Cummings episode. And one of the key themes that emerged there was the importance of a real sense of social solidarity if this is going to work in terms of enabling healthcare data partnerships to operate. And so anything that kind of undermines the sense of we're all in this together would contribute to undermining trust in the process of data sharing. Your other point, which is less about that and is more about the kind of the way we move forward. It feels like it's been a pretty strong theme in the last 3 weeks and before then, that clarity in terms of transparency, the existence of an evidence base of what works, the importance of evaluating mechanism through which healthcare data partnerships are offering value and articulation of what that value is. These are all necessary and indeed foundational if we are going to begin to answer the question, what would build public confidence in these healthcare data partnerships?
Great, thanks. So I'm conscious of time, so I'll try and kind of squeeze in some last few questions to Annemarie and James. So still on that kind of topic of governance, there's a couple of attendees who have asked a question about actually should patients control their own data and decide for themselves basically kind of how to make those decisions and barter with private sector companies directly. So I'll go first to you, James.
Yeah, I mean, data about somebody is obviously something over which they should have agency, right? I mean, that is just a very fundamental principle, which I'm sure we would all agree with. It doesn't always happen, but that is ultimately what the foundation of our data protection arrangements. But of course, the health data that is about you is often, in fact, almost always generated by somebody else. A doctor, a nurse, a care worker, whoever. And so the truth is it's already shared, and it's shared for the purposes of direct care. And I don't think any of us would want to be in a situation where people withdrew their consent for their data being used for their direct care, because that's just downright dangerous. So the question comes is, what are the vehicles on which people come together to make sure that their data is used for purposes they agree with? And ultimately, I think the process you want to follow here is consent. Individual data points or sets of data about individuals alone, probably not worth much beyond the obvious use to me or you in terms of being better treated, but aggregated they become valuable. So it's really about giving people some sense of control and even better ownership over those aggregated vehicles and making sure they benefit. Actually, I'm not sure people want to earn a few pence a week from it. What they really want to see is a better hospital, is better care. And if you can translate the value being generated into those things, then you do see enormous support when it's expressed in deliberative forums like citizens' juries and so on.
Great, thanks, James. And Annemarie, your perspective on the question before we have to wrap up the session?
I think remember that the value is in the trust, not in the data, and the trustworthiness with which the general public holds the National Health Service. And so be transparent, first and foremost, radically transparent, perhaps not in keeping with the way that the government has behaved in recent days and weeks in relation to the larger private sector contracts that have attracted considerable controversy. And make sure that when you deploy the NHS brand in which people are so trusting, that you do that with great care, so that you don't engender their kind of wrath, really, in relation to their data being stewarded by the National Health Service.
Great, thank you so much. So I will wrap up this session there. So thank you so much for all of your very interesting insights into the topic of healthcare data and commercialization. We still have a great deal of questions to get through and to talk about. So the great thing is that for some of you who have the right pass, you will be able to follow us and join us for a Q&A session for the next half hour, where I will try and ask all of these questions that I haven't managed to ask you in this main stage. But thank you so much, and we will be doing a Q&A session pretty soon. I know that there is another session after this on the health stage that I think will start at 4. So do stay tuned in for that session. Thank you very much.
Want access to more CogX videos? Subscribe now for free at cogx.co.